Hello, my name is Patrick Salibi, and I'm one of the HPB Surgery Fellows at Atrium Health in Charlotte, North Carolina. I'll be presenting a single institution's experience of minimally invasive liver surgery 12 years after the Louisville statement. Where do we stand? MIS liver surgery is a burgeoning field. It's continued to have rapid, interesting growth, likely due to the expansion of technology available to assist with these complex cases, as well as our increasing ability to share digital approaches and techniques such as this current conference, which will be provided online and in an e-format. You can see here there's been a rapid exponential rise in the number of publications by year for MIS liver surgery. So how did we get here? The first case of laparoscopic liver surgery was reported in 1994. There was slow uptake initially, but after the 2008 Louisville conference, where institutions established safe guidelines for novices, intermediate, and expert surgeons to begin to expand the field of MIS liver surgery, we began to see increasing interest. This was followed up in 2015 by the Moriaka Consensus Conference and 2018 by the Southampton Consensus Guidelines, also stressing safety when starting to pursue MIS liver surgery. Learning curves have been around for a long time. They were first described in 1922, actually, by the aeronautical industry. The definition of a learning curve is the rate of a person's progress in gaining experience in a new skill. Here we can see that Hopper et al. Put out a paper defining surgical practice learning curves, where during your initial phase, there's a steep learning period, likely during training, at which point you reach an acceptable standard and then go out into practice where you eventually plateau and then decline in ability. Learning curves were applied for laparoscopic liver surgery shortly after the Louisville statement in 2009 by Vigano's group, where they wanted to assess the feasibility and reproducibility of performing laparoscopic liver surgery. And they established that 60 cases was a threshold to achieve consistent outcomes. Here we can see their CUSUM curves for their data. And for MIS liver surgery, they found that the 60 case threshold was the inflection point on their CUSUM analysis. Learning curves today continue to be evaluated. Here we see another European group evaluating fellowship training and how stepwise introduction of complexity in the approach to MIS liver surgery can be performed safely without compromising intra or postoperative outcomes. More recently, as early as this year, there was a 40-study meta-regression analysis looking at both MIS laparoscopic as well as robotic hepatectomies, and they found similar case thresholds of 50 for laparoscopic cases and 47 for robotic hepatectomy cases as the learning curve thresholds. Our own institution wanted to evaluate our institutional data, and so we performed a retrospective query of all of our hepatectomies or hepatic surgeries, I should say, from January 2008 to December 2019. We included all patients over the age of 17. We excluded patients who had missing data or were ablative-only procedures. Our aim was to assess, from an institutional standpoint, could learning curves be determined based on perioperative and postoperative outcomes. We had a total of 1,720 patients which were available for analysis. 842 had undergone ablative-only procedures and 25 had undergone procedures that had incomplete data available. This left us with 550 MIS hepatectomies, with 49 being converted to open during the procedure and 303 intended open hepatectomies to be evaluated. Our patient cohort was, as described here, the mean age was 55, majority of which were female at 57%. The race represented our local population. The BMI also unfortunately represented our local population with BMI of 29. The ASA classification median was 3, which shows the fairly comorbid and moribund state of the patients we take care of on a regular basis. And surgical details, you can see that the majority of cases were minor resections, but when defined by greater or less than 3 contiguous segments, with 21% being major resections. Our early cohort did consist of several hand-assisted cases, which gradually decreased over time, and we had a total of 55% laparoscopic cases and 27% robotic cases. When broken up by tier, based on the Japanese difficulty score established by Ban et al. In 2014, 16% of our patients were in the lowest tier, 45% in the intermediate tier, and 38% actually in the highest tier, even though there were several minor sections. These are in different locations, putting them in this category. The relatively low number of low-tier patients was likely the result of our institution's heavy use of ablation technology in many of these hepatic approaches for malignancies. So our experience when broken up by epoch, we divided our patients into 4-year epochs using 2008 to 2011, 2012 to 2015, and then 2016 to 2019. We found significant differences over time when it came to operative time, EBL, length of stay, and conversion rate. You can see, interestingly, for both operative time as well as length of stay, there was a slightly increase between the first epoch and the second, and this was due to increase in complexity of cases. And then this dropped off gradually by the time we reached the third epoch, with significant differences in all of these categories, as well as our conversion rates dropping from 13 to 7 to 4% over that same period of time. Complications remained stable over this period of time with no significant difference when either evaluated by comprehensive complication index or a Clavien-Dindo grade 3 or higher complication. We saw no difference over the course of our study time period. Readmission rates also remained relatively the same. When evaluating our MIS liver experience by conversion rate, which is a very good surrogate of relative experience due to the fact that conversions are often the result of technical difficulties in the operation or bleeding, we found that during the initial epoch, our conversion rate was approximately 13%, but when looking at the first 2 years, it was actually over 20% in our early experience. This dropped off fairly quickly down to 10% range, and then stayed in this area of around 10% for the remaining 4 years as we began to delve into the robotic MIS hepatectomy approach. And then during our final epoch, our conversion rate dropped less than 5%, which we think was consistent with our plateau in the number of MIS cases performed and has remained consistent since. When looking at MIS hepatectomy cases in an institution, it's always good to look at the total number percentage-wise of cases that are performed in an MIS fashion. And you can see here that during our study time period, during the initial epoch, we were doing most of our cases open during the first year and second year. And then during that third year, we saw the inflection point where our number of MIS cases crossed over to and were equal with our open cases. And during that same time period is when the conversion rate started to drop. During the second epoch, again, our MIS cases continued to increase in frequency, now representing 70% of our population. And during the final epoch, it represented 75% of our population where it has plateaued. Overall, the conclusions of this study would say that MIS liver surgery is feasible and safe, and intraoperative factors remain the best predictors of overall learning curve, even at an institutional level. And we believe that a ceiling effect can be viewed as a valid measure of an institutional learning curve with a goal of 70%.